Thank you, Ken.
Well, it's my pleasure to also introduce Dr. Ilnitsky. Sarah and I met about 6.5 years ago. Hey, Sarah. And she joined our great team in Edmonton after completing her fellowship at the University of Western Ontario in London. And she did her undergraduate degree in obstetrics and gynecology as a specialty at the University of Alberta, which is my alma mater as well. Dr. Ilnitsky practices at our Edmonton clinic, and she's got a special interest in fertility preservation for people with cancer, as well as with trans and non-binary people. She's very proud to work in Edmonton and has deep roots in that community and works alongside of our great team there. She's also our incumbent medical director, and because I've worked with her, I can attest that she's a physician with unparalleled excellence. So Sarah, I'll turn it over to you.
Great, thanks, Ken. I'm just going to share my screen here. Okay, so it's my pleasure today to talk about diagnosing and managing early pregnancy loss. This is another one of my special interests. Before I begin, I would like to acknowledge that pregnancy loss is a difficult and emotional topic. In addition to caring for patients who have experienced pregnancy loss, many attendees have likely been impacted by pregnancy loss in their own lives. I'll do my best to approach this topic in a sensitive manner, but please feel free to do whatever you need to do to ensure your well-being during and after this presentation. And furthermore, I acknowledge that while most people who are capable of pregnancy identify as women, not all persons who are capable of pregnancy and of being impacted by pregnancy loss identify as women. So I'll do my best to use gender-neutral language throughout this presentation. So your patient... Oh, and sorry, back to my objectives. So I'd like to today review early pregnancy complications and the diagnostic criteria of early pregnancy loss, review the considerations and management options of early pregnancy loss, and discuss an evidence-based approach to recurrent pregnancy loss. So your patient calls the office with a positive home pregnancy test and vaginal bleeding. What do we do now? The first step is to establish the date of her last menstrual period, but this can be unreliable. In most cases, a serum HCG can be ordered to confirm pregnancy, but a single HCG can't diagnose the location or viability of a pregnancy. The mean doubling time of HCG was established at just under 2 days back in 1981, but multiple studies on the HCG rise published over the last few decades have established a minimum expected rise in HCG that is different than what we used to use, which was the doubling time of 2 days. So the expected rate of rise for a viable pregnancy is now much more conservative and actually depends on the initial HCG value. The expected rate of rise can be as low as 33% when the initial HCG is greater than 3,000. There's also an established rate of decrease, and approximately 95% of women with a spontaneous early pregnancy loss will have a decrease in HCG concentration of about 21 to 35%. Next up for this patient will be to arrange an ultrasound. And the SOGC recommends a first trimester ultrasound for pregnancy dating between 7 and 12 weeks. This can be combined with the comprehensive scan at 11 to 14 weeks if this is planned. There are some indications, though, for early pregnancy ultrasound, which would include concern or suspicion of ectopic pregnancy, bleeding in early pregnancy, recurrent pregnancy loss, or in some cases, patient request or reassurance. Now, importantly, if you order an ultrasound less than 7 weeks, it's not accurate for dating, so it will need to be repeated. And typically, we would do that about 2 weeks later. And also below 7 weeks, bradycardia or no cardiac activity can be normal, and so it's not necessarily a cause for concern. These are the possible outcomes of an ultrasound in a woman with a positive pregnancy test. I will briefly discuss ectopic pregnancies and pregnancies of unknown location because an understanding and approach to these can be life-saving. Ectopic pregnancy refers to any extrauterine gestations. These could be tubal, which account for about 90%, abdominal, cervical, within a C-section scar, or ovarian. Typical signs and symptoms would include vaginal bleeding and or abdominal pain, which would occur after a period of amenorrhea. Symptoms of a ruptured ectopic would be presyncope or syncope, hemodynamic instability, or an acute abdomen. Importantly, every woman of reproductive age presenting with abdominal pain should be screened for pregnancy, regardless of contraception use. And ruptured tubal ectopics account for about 2.7% of pregnancy-related deaths. Diagnosis of ectopic pregnancy would be made by transvaginal ultrasound. Pregnancy of unknown location is a separate entity. This is when there's a positive pregnancy test, but no intra or extrauterine gestation on ultrasound. And very importantly, this is not a diagnosis. It's something that needs to be further investigated. This algorithm is extremely helpful. It's from the Canadian Medical Association Journal for the management of pregnancies of unknown location. So once a PUL is identified, the patient should be assessed for signs and symptoms of ectopic. If any are present, then the pregnancy should be managed as an ectopic. In an asymptomatic patient, an HCG level should be done immediately. They should be counseled about signs and symptoms of ectopic pregnancy, and a follow-up HCG scheduled for 48 hours. That's that part right there. The ratio of these HCG levels can establish whether the risk for ectopic pregnancy is high or low and guide management. For high ectopic risk, the ultrasound and HCG can be repeated in 48 hours. And if the pregnancy of unknown location is persistent, then we can move on to further monitoring if clinical situation warrants, or definitive management with methotrexate. If at any point the patient develops ectopic symptoms, they should be investigated and managed as an ectopic pregnancy. So she lets you know that her last menstrual period was about 8 weeks ago. She has no risk factors for ectopic and no symptoms other than vaginal bleeding. You do order an ultrasound, and the ultrasound report shows a non-viable intrauterine pregnancy at 7 weeks and 5 days. So now what do we do? Well, this is a call that I make at least weekly and sometimes a few times a week, depending on what our pregnancy outcomes look like. And I'm sure many of you do that as well. The most common questions I am asked are you sure? Why? How common is this? Will it happen again? And what do we do now? So what are the ultrasound criteria for diagnosis of non-viable pregnancy? These criteria were established by the Society of Radiologists and Ultrasound in 2012 to ensure that a viable pregnancy is never incorrectly diagnosed as non-viable. The cutoffs provide a specificity and positive predictive value of 100%. Patients will often ask if the ultrasound could be wrong or if it should be repeated, but you can reassure them that based on these criteria, the diagnosis is certain. So if you have a crown rump length of 7 or more millimeters and no heartbeat, that would be diagnostic, or a mean sac diameter of 25 or more millimeters without an embryo present. Furthermore, if you have the absence of an embryo with a heartbeat 2 weeks or more after a scan that showed a gestational sac without a yolk sac or an empty gestational sac, that's diagnostic. Or the absence of an embryo with a heartbeat 11 days or more after a scan that showed a gestational sac with a yolk sac. And then in our world, because when we do frozen embryo transfers, our dates are exact, we would also say that the absence of an embryo with a heartbeat at 7 weeks gestational age after an embryo transfer would also be diagnostic. These are just ultrasound images to show you what that might look like. So the first image is a gestational sac, which measures 29 millimeters, confirming a non-viable pregnancy. And the second image is an embryo with a crown rump length corresponding to 8 weeks, 4 days, or 20 millimeters without cardiac activity, again, confirming a non-viable pregnancy. What are the causes of early pregnancy loss? Some of this has been touched on already by Dr. Dunn, but in terms of just definitions of pregnancy loss, it is the spontaneous demise of a pregnancy before the fetus reaches viability, which would be from conception to 24 weeks of gestation. In general, about 12 to 15% of clinically recognized pregnancies end in miscarriage. But interestingly, about 30 to 60% of all conceptions abort within the first 12 weeks, and 50% of those go unnoticed. The established causes of early pregnancy loss are fetal chromosomal anomalies, accounting for 50% of losses. Trisomies are the most common aneuploidies, and trisomy 16 is the most common trisomy. That's what that karyotype there is showing. Structural abnormalities account for 18% of early pregnancy losses, and this is based on a study using embryoscopy after diagnosis of a non-viable pregnancy. Other contributors include poorly controlled diabetes, as we heard about earlier, maternal obesity, and heavy alcohol and drug use. Maternal age is a risk factor for early pregnancy loss, as Dr. Dunn described, related to embryo aneuploidy. As eggs age, the internal machinery responsible for dividing the chromosomes equally between the cells becomes less effective. A higher proportion of eggs will have too many or too few chromosomes after completing meiosis, resulting in aneuploidy after fertilization. In general, the risk is stable at about 15% until age 35, at which point it starts to increase. And by age 45, we're looking at about an 80% chance of pregnancy loss in a clinically recognized pregnancy. And that graph actually very nicely mimics the aneuploidy graph that Dr. Dunn showed earlier. Previous pregnancy losses are another risk factor for early pregnancy loss. This becomes significant after 3 losses. We can see here that the more early pregnancy losses a person experiences, the less likely they are to achieve a live birth. So beginning with 3, you can see per pregnancy loss, there's a decline in the likelihood of a live birth over time. Most importantly, you can reassure your patients that there is nothing they did or did not do that caused the early pregnancy loss. Factors that are not implicated would be working, heavy lifting, intercourse, exercise, travel, or any dietary changes or specific foods. So now that you've made the diagnosis and counseled your patient, they will want to know what the next steps will be. There are 3 options to manage early pregnancy loss: expectant, medical, and surgical. Expectant management is a watch and wait approach. The pros are that it's private, it's considered natural, and that you're not intervening in any way, and it can be up to about 80% effective. Some of the cons are that it's unscheduled, so the pregnancy loss can begin at any point without much warning. There's no safety data in the 2nd trimester, and it requires a long timeline of up to about 8 weeks. It's also less successful in asymptomatic or missed pregnancy losses. Medical management uses misoprostol, a prostaglandin, to soften the cervix and cause uterine contractions to expel the pregnancy. Misoprostol is taken vaginally or sublingual at a dose of 800 micrograms, which can be repeated in 3 to 24 hours if there has been no effect. Mifepristone is an antiprogesterone, which can be given 24 hours before misoprostol. A multicenter randomized double-blind controlled trial from 2020 showed a significant increase in complete expulsion and a significant decrease in the need for D&C compared to misoprostol alone. Mifepristone misoprostol is available as mifepristone at a cost of about $300 to $400, which is compared to $5 for misoprostol alone. So if not covered by private health insurance, probably not the best option, but most society guidelines are recommending it if available. Some of the pros of medical management are, again, it's private, so it would happen at home. It expedites the tissue passage. It's relatively schedulable. Usually it happens over a weekend, so you can decide when to take the medications and just stay at home for that time period. It avoids surgery, and it's about 84% effective. Some of the cons are that it may require 2 doses, and specifically the amount of bleeding and pain can be shocking or upsetting to some patients, so it's important to counsel them about what to expect and provide them with adequate pain control to manage this on their own at home. And they may ultimately require a D&C. Some of the contraindications would be infection, hemorrhage, severe anemia, or if they have a bleeding disorder. And then finally would be surgical evacuation with a suction dilation and curettage. Pros of this are that it is scheduled, so you get an OR date and you arrive and have your procedure. There's minimal downtime, and it's about 99% effective. The cons are that you are assuming surgical and anesthetic risks, and there is a risk of post-op adhesion formation, although this is extremely rare. For expectant and medical management, ACOG recommends a repeat ultrasound in 7 to 14 days to confirm the absence of a gestational sac and an endometrial thickness of less than 30 millimeters, which I think is an important thing to highlight. So often you see an ultrasound after pregnancy loss with a thickened lining and wonder about retained products, but actually up to 3 centimeters is acceptable. And D&C does not have any specific follow-up recommended. This is a bit of a change in guidelines, and it's an important question. So do I need to give Rh immunoglobulin to an Rh negative person experiencing a miscarriage? The earliest that the Rh antigen has been identified on fetal red blood cells is 7 weeks and 3 days. So the SOGC has revised their guidelines, and for threatened spontaneous or induced abortions, ectopic pregnancies, or molar pregnancies before 8 weeks, and between 8 weeks and 12 weeks gestation, the SOGC suggests not administering Rh immunoglobulin. If the patient is very risk averse and between 8 and 12 weeks, it could be considered with appropriate counseling. Well, this is her 2nd pregnancy loss. So now she wonders, what do we do next? So I want to take a few minutes to touch on the recurrent pregnancy loss workup and management of unexplained recurrent pregnancy loss. The European Society of Human Reproduction and Embryology have an updated guideline as of 2022, which outlines an evidence-based approach to RPL, which may be different from what many of us learned in training. This is an extremely detailed document. I'm going to take a very high-level approach. It is open access, so you can access it on the ESHRE website if you are interested in looking into it further. This is my Royal College study card from not that long ago, I don't think, back in 2017. So the definition, from my recollection at that point, was 3 or more losses of a clinical pregnancy. And the differential included immunology, statistics, infection, thrombophilia, anatomy, genetics, environment, and endocrinology. The definition has changed even before my Royal College exam. So as early as 2012, ASRM updated it to include 2 or more losses of a clinical pregnancy confirmed by ultrasound or histopathology. But in 2018, ESHRE refined that even further and changed it to just 2 or more pregnancy losses, defined as any loss below 24 weeks. And this would include non-visualized, like biochemical or pregnancies of unknown location, which were over 6 weeks, excuse me, by last menstrual period. It does not include ectopic or molar pregnancies. And the updated definition is based on findings from a number of observational studies where they found there was an equal distribution of associated factors between those with 2 and 3 or more losses, as well as consecutive and non-consecutive losses. Individualized testing and treatment is one of the is an important recommendation that came from this ESHRE guideline. So it's important to tailor the investigations to the couple, looking at factors like age, fertility or subfertility, pregnancy history, family history, and previous investigations and treatment. It's important to explain that no cause may be identified, and 50 to 60% of cases are unexplained. There's also, it's possible that no good treatment may be available, even if a cause is identified. It's important to discuss the time frame of results and the need for contraception in the meantime. And even if no cause is identified, you can offer a treatment plan, including regular visits and ultrasounds. So to start with kind of the simplest thing for us to counsel on, but probably one of the hardest things for patients to manage, which are the lifestyle factors. So many of these things are just sort of good health practice. So smoking cessation, although not directly related to recurrent pregnancy loss, it does have a negative effect on obstetric outcomes. And so smoking cessation is recommended. Obesity is definitely higher, more common in recurrent pregnancy loss. And they do have a higher miscarriage rate within that population compared to non-obese patients. So weight management is an important factor. Things like caffeine, exercise, alcohol, again, good practice to optimize those aspects, but not a lot of good data in the recurrent pregnancy loss population. Genetics is one of the things we want to look at, and that would be karyotypes for both partners. Abnormal parental karyotypes are found in between 2 and 3.5% of couples with recurrent pregnancy loss. This is managed with expectant management versus IVF with PGT for structural rearrangements. And that is to identify embryos that have, in which the rearrangement has passed on an unbalanced amount of genetic information. So this is a Robertsonian translocation. We can see here that the majority of these possible zygotes or outcomes from fertilization are abnormal. So 2 are normal, but 4 are not. And so that's where PGT can be helpful. That being said, the chance of an ongoing pregnancy affected by an unbalanced translocation, so this is if they were to continue to try naturally and conceive, but then have a child with an unbalanced amount of genetic information, which can have consequences for health and development, is about 1 to 3% in couples that are identified carriers, and 0.02% in the unselected RPL population. Female factors account for about 50 to 60% of recurrent pregnancy loss, and we'll go over a summary of the investigations in just a minute here. But that means that 40 to 50% are unexplained, and there's now more interest in determining the effect of male factors on recurrent pregnancy loss. There is an increased risk of miscarriage with increasing paternal age from 30 to 44, and this is highest at and above age 45. Poor semen parameters were also associated with recurrent pregnancy loss, and ESHRE has actually updated their guideline to recommend sperm DNA fragmentation testing, which can be arranged by a fertility clinic or a fertility urologist. As Dr. Bach highlighted in our first talk, lifestyle factors can also impact sperm quality and the risk of recurrent pregnancy loss. So they're an important strategy to counsel male patients about. So things like smoking, alcohol, cannabis, and occupational exposures. This is a list of non-recommended tests. So patients will often go to Dr. Google or other providers and find this list of things that they think may be implicated in their recurrent pregnancy loss. And ESHRE has reviewed the data for all of these, and these are things that we should not be testing for. So thrombophilia screening, including INR, PTT, protein CNS, factor V Leiden, things like that. Prolactin is not necessary unless they're symptomatic. Anything immunological like NK cells, HLA, or cytokines. PCOS testing isn't necessary. And endocrinological testing like ovarian reserve, luteal phase deficiency isn't helpful either. So just to review what is helpful. So what they recommend is routine investigations would be genetics, as we discussed, so parental karyotyping. In terms of immunology or thrombophilia screening, it's just antiphospholipid antibody testing. So that's lupus anticoagulant, anticardiolipin, and beta-2 glycoprotein. With regards to endocrinology, it would just be a TSH and TPO antibodies. For anatomy, we want to assess for congenital uterine abnormalities. So we would typically do a 3D ultrasound or SHG to look for something like a uterine septum specifically. Also, there could be acquired malformations like polyps or submucosal fibroids, which could be contributing. And then in terms of male factor, assessing lifestyle factors is important. And then in a select patient population, you could consider referral for sperm DNA fragmentation assays. In terms of treatment for recurrent pregnancy loss, so if you find a genetic background, as discussed earlier, so we would refer for genetic counseling. We discuss the risks and benefits of treatment, including PGT for structural rearrangements, and refer to a reproductive endocrinologist. For thrombophilia, so antiphospholipid antibody syndrome, we'd start aspirin preconception and then low molecular weight heparin once they're pregnant. And then consider hematology consultation if you're at all uncomfortable with that process. In terms of endocrinologic abnormalities, we would want to treat overt hypothyroidism with levothyroxine. We'd screen patients with subclinical hypothyroidism and TPO antibodies in their next pregnancy and treat them if they're hypothyroid, and then treat hyperprolactinemia. And then with the male factor, again, lifestyle counseling, and then potentially referral to REI if you've gone down the road of sperm DNA fragmentation testing. And then finally, to discuss one of the most challenging diagnoses we deal with, which is unexplained recurrent pregnancy loss. So as I mentioned earlier, 50 to 60% of cases will be unexplained, but in practice, this is likely higher, especially with RPL investigations after 2 losses and the inclusion of biochemical pregnancies. The management consists of expectant management, where they have a likelihood of live birth of 70 to 90% in patients under 35. Close clinical monitoring, and then the consideration of products of conception testing for future pregnancy losses. I wanted to highlight this study because I was taught that close clinical follow-up was the only treatment for unexplained recurrent pregnancy loss with good evidence. So here's the evidence. So this study was from 1984. It included 158 couples with 3 or more consecutive pregnancy losses. And they were divided in a non-randomized fashion into routine prenatal care, which was 42 patients, and TLC, which was 116 patients. And the way they were divided was based on if they lived within a reasonable distance of the hospital. So TLC consisted of weekly medical and ultrasound examinations, avoidance of heavy work, travel, and sexual activity. And then they found that the live birth rate in the TLC group was 85% versus 36% in the control group. Now, the results are impressive, but the study design is obviously quite poor. That being said, patients really do appreciate the extra monitoring. There's essentially no risk to them to have an extra ultrasound or 2 in the first trimester. And it's not overly resource intensive. So I do continue to employ this, even though the data is not that strong. Progesterone and unexplained recurrent pregnancy loss is a controversial topic, and historically the evidence has been contradictory, but on balance favored no benefit in terms of live birth rate. There have been 2 progesterone trials in the last few years, PROMISE and PRISM, in which subgroup analysis showed an increased live birth rate in progestogen-treated women with at least 3 previous pregnancy losses and bleeding in the current pregnancy. So there may be benefit, but in this very selective patient population. Products of conception testing or analysis of pregnancy tissue. So the prevalence of chromosomal abnormalities in miscarriage tissue is still 39% in recurrent pregnancy loss. Doing products of conception testing provides information about the current loss, but does not rule out underlying conditions. So it's just an adjunct to your other testing. There's no effect on prognosis that's been established. Most provinces will have public testing, but there is also private testing available. The private products of conception testing is provided by Honora, it's called Honora, which is provided by Natera, and then iGenomics also has a products of conception test. It can test for aneuploidy and triploidy, deletions and duplications, and uniparental disomy. And importantly, it returns results in about 99% of cases. And in my experience with the provincial healthcare covered testing, I almost never get a result. Usually, they usually report maternal cell contamination. And so I find this actually quite helpful in getting that information for patients. The cost is about $1,000 and it's paid directly to the company by the patient through the testing kit. And if you want more information about these, the websites are here on the slide. So other treatments for current pregnancy loss, again, things patients might bring to you to ask about. Esri recommends against things like lymphocyte immunization therapy, IVIG, glucocorticoids, and aspirin and low molecular weight heparin. And they found that there's insufficient evidence for endometrial scratching, so it would be a biopsy of the lining in the cycle before to create an injury, GCSF, or intralipid therapy. And then to talk quickly about prognosis. So the following graphs and prognostic tools are available in the Esri RPL guideline, which, as I mentioned earlier, is open access. So here we can see that the probability of live birth is a function of maternal age and prior pregnancy losses. As expected, the probability of live birth decreases with advancing age and number of previous losses. So here you can take your patient's age and the number of losses they've had and give them a general idea of what their probability of a live birth is. And this graph is, I think, quite useful because not every patient has only ever had losses. Some will have had a loss, had a live birth, had another loss or two. And so looking at previous pregnancy loss history is also very important. So this is the probability of live birth based on sequence and outcome of 3 prior pregnancies. And as expected, a live birth at any point improves the chance of another live birth. There would be some reasons to refer to REI. And of course, if you feel like any of this workup is out of your depth, we're more than happy to see these patients. It is well within our wheelhouse to do a recurrent pregnancy loss workup. But specifically, if your patient is over 35, as we know, the risk of aneuploidy is increased specifically over 35. And so they may want additional counseling about options related to genetic testing. If they have any evidence of infertility or subfertility, i.e. they've been trying for 6 to 12 months, or it's taking them a long time to get pregnant between their pregnancy losses. They have a karyotype showing a translocation, or if they have products of conception testing showing aneuploidy, and again, they want more information about IVF and genetic testing. And that is all I have. That was a fast and furious review of early pregnancy and recurrent pregnancy loss, but are there any questions?
Thank you so much, Sarah. That was really, really good. This is a topic that's, so difficult to keep up with the latest evidence. So thank you for that concise review. There's a lot of good questions in the chat. Questions about, does biochemical pregnancy count towards RPL criteria, about genetic workup after 2 miscarriages. There's a question about ROGAM and what would be the risks. And there's a question about occupational exposures, as well as activity and whether that increased risk in the first trimester. If you don't mind, I would ask you to answer those if you could by typing. And I just want to call everyone's attention to all those questions will be answered in the chat. We just want to make sure that we stay on time. So is that okay with you, Sarah, to
Absolutely.
type those? Thank you so much. Thank you for everyone for your questions. Clearly, people are really interested in your topic.